Hey everyone, welcome back to Izzy Medicine, where we unpack the endocrine chaos without letting your blood pressure spiral like an aldosterone surge. Today, we're diving into, you guessed it, hyperaldosteronism. It's a condition that likes to pretend that it's just plain old hypertension, but it's secretly messing with your potassium, your pH, and your diagnostic confidence. Womp womp womp. If you guys don't know the reference, I was trying to be Debbie Downer from Saturday Night Live. Most of you are probably way too young to know who that is. Look it up. She's funny. Anyways, let's move on. So imagine that you're on an internal medicine floor or in your primary care office, and you have this relatively young patient, maybe 34 years old, coming in to follow up on long-standing hypertension. She's on 4 different antihypertensives, including a calcium channel blocker, an ACE inhibitor, a beta blocker, and a thiazide. And you check her blood pressure, and it's still in the 160s, and she also reports that it's elevated at home. She also tells you that she's been feeling off for months. She's exhausted, even though she sleeps really well, and she gets frequent muscle cramps in her legs, and she noticed some heart palpitations. And occasionally she's constipated on top of that. You decide to do an exam, and you check her labs. They come back, potassium is 3, sodium is slightly elevated, her bicarbonate is up, magnesium a little low, and renal function is otherwise okay. She's not on a loop diuretic, so you replete the potassium, but when you recheck it 2 days later, it's back down again. And that's when you start wondering, wait a second, something's not adding up. What's happening? And you're considering that this could possibly be secondary hypertension. Maybe it could be aldosterone. So what exactly is hyperaldosteronism? Well, the name kind of gives it away. It's a condition where there's too much aldosterone, and it messes with your kidneys, electrolytes, and blood pressure, and we have to figure out where it's coming from. But before we go into trying to figure out the causes, let's rewind and talk about how aldosterone is normally regulated, because understanding the normal is very important to then figuring out the abnormal. So aldosterone is part of the renin-angiotensin-aldosterone system, RAAS for short. It's basically a hormonal chain reaction that starts in the kidney and ends in the adrenal cortex. When blood pressure drops, or sodium levels fall, or there's decreased perfusion to the kidney, the juxtaglomerular cells in the kidney release renin. Renin converts angiotensin into angiotensin 1, then ACE, angiotensin converting enzyme, which is mostly found in the lungs, converts angiotensin 1 into angiotensin 2. And angiotensin 2 has several jobs. What it does is it causes vasoconstriction, it increases thirst, and it stimulates ADH. All of these are meant to maintain blood pressure, increase thirst to bring more volume in, stimulating ADH to prevent volume loss, vasoconstrict to maintain tone. And another thing that angiotensin 2 does is it stimulates the adrenal cortex to produce aldosterone. What does aldosterone do? Aldosterone then acts on the distal nephron, and there it reabsorbs sodium, it excretes potassium, and it dumps protons. This boosts blood volume, and it raises blood pressure, and it rebalances electrolytes. So when everything is stable again, when the body gets that message, renin levels fall, and this beautiful negative feedback loop resets. But in hyperaldosteronism, this feedback loop is broken, and nothing's working. So we get 2 types of hyperaldosteronism, and let's break them down. We have primary hyperaldosteronism, and here the adrenal gland is the problem. What it's doing is it's overproducing aldosterone independently of renin. So let's talk about the causes. We have adrenal adenoma, also called Conn syndrome, and this is a benign unilateral tumor that secretes aldosterone autonomously. By autonomously, it means that it's just doing its own thing. It's not listening to any feedback loop. It's not listening to the renin dropping, and it still pushes out aldosterone. We have bilateral adrenal hyperplasia, and here both glands are enlarged and overactive. This can typically happen from some mutations that affect ion channels in the adrenal gland, and it's pushing aldosterone out and not responding to renin. Lastly, there's a rare form of adrenal carcinoma, and this is the aggressive version. It also is usually unilateral, and it has systemic symptoms on top of having high aldosterone. So the patient can have weight loss, they can have fevers, they can have night sweats, so basically have constitutional signs consistent with cancer. Additionally, they will have an MRI that looks a little bit more irregular than a regular adenoma. In all three conditions, in primary hyperaldosteronism, what we will see is high aldosterone and low renin, because the feedback loop is trying to reduce renin in order to send a signal to the adrenals to stop producing aldosterone, but the feedback loop is broken, it's not working. All of these conditions are pretty much autonomously pushing out aldosterone unnecessarily. Now let's flip this. In secondary hyperaldosteronism, aldosterone is elevated because renin is elevated. The adrenal glands are doing their job just fine, responding to the renin being abnormal. What are the drivers for elevated renin? Let's review our causes. So, renal artery stenosis is when the renal artery narrows. It can be due to atherosclerotic plaques in older adults or fibromuscular dysplasia in younger women. And what happens is this narrowing reduces the pressure of blood flow entering the kidney. Even if systemic blood pressure is high, the kidney interprets this local pressure drop as underperfusion, because this is the artery that perfuses the kidney. And that triggers a response from the juxtaglomerular cells. And when they sense this, they sense that the body is hypotensive. That's how they perceive it. And they increase renin secretion. And this triggers the RAAS cascade. And this leads to ultimately more aldosterone. So despite having enough or even too much circulating volume, the kidney keeps pushing the system into overdrive because it perceives hypotension and a problem. Another such problem is heart failure, specifically with reduced ejection fraction. So the heart is failing and it can't pump enough blood forward, so renal perfusion drops. And the kidneys, again, don't measure overall volume, they just sense pressure and flow. So even with high total blood volume, the poor forward flow means that the kidneys feel underfilled and they feel panicky. They're panicking that they're not getting oxygenated because of this poor forward flow. So again, juxtaglomerular cells perceive this as hypotension and they crank out renin. And that kicks off the RAS cascade and it stimulates more aldosterone production to retain sodium and water. And this is the attempt to restore perfusion pressure, even though the actual problem lies with a malfunctioning pump. There's heart failure. Additionally, we have another cause that can create this situation, cirrhosis. In advanced liver disease, the liver becomes fibrotic and scarred. All the vessels there are not pliable. This increases resistance to blood flow in the portal system. And this is where we get portal hypertension. Basically, as a result, to try to compensate for all this rigidity, the body releases vasodilatory substances like nitric oxide, and it releases it into splanchnic circulation. What happens is this causes a widespread vasodilation in the gut and in the abdominal vessels. And when this vasodilatory situation happens, blood gets trapped there and it decreases the amount of blood effectively circulating to vital organs. Again, the kidneys sense this relative hyperperfusion and they respond by increasing renin. We go back into our RAAS system and aldosterone gets produced again at an abnormal amount, retains sodium and water, and it raises intravascular volume. In the case of cirrhosis, this just worsens the ascites and the fluid accumulation and the edema that these patients are already experiencing, and we have kind of a cyclical situation. Lastly, there's a rare renin-secreting tumors kind of situation, and they secrete renin autonomously, and they push aldosterone up as a downstream effect. So in secondary hyperaldosteronism, to sum up, we have elevated renin and elevated aldosterone because the cause is a renin cause versus an adrenal aldosterone overproducing situation. So let's circle back to our patient. She's hypertensive despite multiple medications. Her potassium keeps crashing even though we attempted to replete it. And she's showing signs of metabolic alkalosis. And that's the classic picture. Let's talk about what's happening on the physiological level because it's very important to understand instead of just memorize what the telltale signs of hyperaldosteronism. Where does hypertension come from in hyperaldosteronism? Aldosterone makes the kidneys hold on to sodium. And where sodium goes, water follows. So what happens is the extra fluid increases blood volume, which raises blood pressure. But over time, when there's persistent blood pressure elevation, this can put pressure on the blood vessels and they stiffen. And that makes it even harder for the body to regulate blood pressure because there's no pliability in the vessels. and it stays high despite multiple medications. Where does the hypokalemia come from? Again, aldosterone makes the kidneys dump potassium. At the same time that it retains sodium, it's trying to exchange the sodium for potassium, so it's pushing potassium out. This drop in potassium lowers the levels in the blood, and the resulting drop in serum potassium also affects the resting membrane potentials. It makes it harder for muscles and nerves to depolarize, and this causes muscle cramps and weakness, and this is where our patient is probably experiencing muscle cramps from. Also, if we did an EKG on our patient and if there was significant enough hypokalemia, we would notice that hypokalemia can lead to repolarization abnormalities. So we can have findings such as flattened T waves, U waves, ST depressions. In severe cases of hypokalemia, we can even get to prolonged QT intervals. So this electrical instability, it raises the risk of ventricular arrhythmias, and it can include potentially life-threatening ones like torsades de pointe, for example. So our patient's palpitations, maybe that's what's happening, and we should do an EKG. And the cramps could be from the hypokalemia as well. These are classic signs of potassium depletion and causes of cardiac irritability. The metabolic alkalosis happens because aldosterone also drives proton secretion in the collecting duct, and as a result, a rise in serum pH, and we get an elevated bicarb that we saw on the labs. Now it makes sense why she was having an elevated bicarb level. Where is her fatigue coming from? The fatigue is because potassium plays a crucial role in maintaining the resting membrane potential of skeletal muscles and nerve cells. And again, as we talked, low potassium levels impair depolarization, and it slows down nerve conduction and transmission and muscle contraction. And this leads to muscle fatigue, generalized weakness, the cramps that she's experiencing, and especially in large muscle groups like the calves. So again, the potassium really plays a role in symptomatology. Before we talk about diagnosis and treatment, let's talk about when we should screen for hyperaldosteronism. Let's say we see a patient like that, and let's say she didn't tell us that she's having symptoms. She's just on multiple medications and the blood pressure is not budging. Should we screen her? Let's think about it. So the criteria for screening is if we have patients with hypertension resistant to 3 conventional antihypertensives, she's already on 4, and there's resistance to treatment, we should consider testing for hyperaldosteronism. If we have hypertension with spontaneous hypokalemia or diuretic-induced hypokalemia. So we know why spontaneous, right? If we notice hypokalemia, it's possibly one of the signs, and the hypertension is not responsive. But why diuretic? Is because diuretic-induced hypokalemia seems to be at higher incidence in hyperaldosteronism because there's already a potassium push and potassium loss, and the potassium loss seems to be excessive with standard diuretic doses. So when someone drops their potassium dramatically in a regular dose of hydrochlorothiazide, it could be a red flag. We do an imaging on a patient because they were having some abdominal pain, and we find an adrenal incidentaloma. Like incidentally, we find something on the another place to screen for hyperaldosteronism is if there's hypertension and a family history of early onset hypertension or stroke before age 40. Why? Because several genetic forms of hyperaldosteronism exist, like familial hyperaldosteronism types 1 through 4. These hereditary variants can run in families, and they can cause devastating early cardiovascular complications if they're not caught because the onset is so early and the damage to vessels is so profuse. Another screening is hypertension in a first-degree relative with confirmed primary aldosteronism. So if they have a mom or a dad that have primary aldosteronism, screen them. And all hypertensive patients under 40 should be screened for hyperaldosteronism. If we have a 25-year-old that suddenly develops really high blood pressure, screen them. Remember, it's not rare. Primary aldosteronism accounts for about 5 to 10% of all hypertension cases and up to 20% of resistant hypertension. So if you're thinking, this could be aldosterone, you're probably right more than you think. So now let's say we decide that this could be a possibility. What do we do? What do we order next? The first step is we order labs. We check plasma aldosterone and renin activity. And if aldosterone is high and renin is low, we think it's primary, one of the primary causes, maybe an adrenal adenoma, maybe a hyperplasia. If both are high, we think secondary because we have renin that's elevated as well. What we can do is we can calculate the aldosterone to renin ratio. And if it's over 20 to 30, that kind of points that the aldosterone is so high in comparison to renin, probably primary. But sometimes these values can vary based on posture, sodium intake, medications. So we don't stop there. We confirm with a suppression test. What we do is we give the patient saline, either IV or sodium tablets. And if the aldosterone levels don't budge, it means that the adrenal glands are not listening, because if there's increased sodium, there should be a decrease in renin. There should be a signal that's going down the RAAS cascade telling the adrenal glands to reduce aldosterone production. And if that's not happening, then it means that it's primary hyperaldosteronism and the adrenal glands are not cooperating. So that's confirmation. The next step is imaging. So what we can do is we can get a CT or MRI of the adrenal glands. And if we see a mass, you're thinking adenoma. If both glands are enlarged, it's likely hyperplasia. If we're not sure, if it's inconclusive, what we can do is we can do the gold standard, which is adrenal vein sampling. And here you draw blood directly from each adrenal vein. If one side is pumping out way more aldosterone than the other, then we have a unilateral situation, like likely an adenoma. If both are elevated, it's bilateral, and it could be hyperplasia. Now, what do we do for treatment now that we've figured out? If it's an adenoma, it's surgery. Surgery is curative. Take it out and the aldosterone levels normalize. If it's bilateral hyperplasia, we don't take out both glands because we need the cortisol. So instead, what we do is we treat with aldosterone blockers like spironolactone or palpitations. And these mineralocorticoid receptor antagonists, they block aldosterone's effects. They help lower blood pressure, they raise potassium, and they reverse the alkalosis. And you'll often see improvement in symptoms too. Patients feel less fatigued, the potassium stabilizes, less muscle cramps, and blood pressure improves, and overall well-being improves. Also, there are some exciting newer options on the horizon, which is always cool. And there are selective aldosterone synthase inhibitors that are being developed, and they target the production of aldosterone at its source rather than just blocking the effects. These newer drugs inhibit the enzymes responsible for the final steps of aldosterone synthesis. These newer drugs are more selective and they might have fewer side effects. They're still in clinical trials, but it's a promising direction, and it's exciting to have kind of a little bit more specific targeted medications. It's a little bit in line with precision medicine, and I'm very excited about that. So let's bring it to a close. So if you have a patient with hypertension that's not responding to medications, if they have unexplained hypokalemia and they have metabolic alkalosis, especially if they're young, think about hyperaldosteronism. And then the labs will point us in the right direction. Then we do confirmatory tests and imaging, and that will seal the deal. And we have treatments that we can implement. All right, guys, that's a wrap on this episode of Izzy Medicine. If you found this helpful, which I hope you did, I hope you learned, I hope you had fun, I hope I was slightly entertaining, although I probably won't quit my day job and won't perform at a comedy cellar anywhere anytime soon. But if you liked it, please like, subscribe, drop a comment. And until next time, stay curious, keep learning, and I'll see you in the next lecture. Bye.